are going to study trigeminal neuralgia. This activity is guided by Dr. Bhushan sir and Dr. Pandey sir. So first of all, definition is for 1 mark, etiology 1 mark, clinical feature 2 mark, diagnostic criteria 1 mark, differential diagnosis 1 mark, and management is for 4 marks. Other names of the disease are trifacial neuralgia, tic doulorex, Fothergill's disease, and suicidal disease. Tic doulorex means rapid jerking, and this name was given by Nicholas Andri. Fothergill's disease is named after John Fothergill, who was a person who did detailed study of trigeminal nerve. And suicidal disease because this condition causes extreme pain. Definition: it is defined as sudden, usually unilateral, severe, brief, stabbing, lancinating, paroxysmal, recurring pain in the distribution of one or more branches of the fifth cranial nerve. So it is sudden, with 8 words which describe the trigeminal pain. So first is sudden, that is it starts suddenly. Unilateral, that occurs on one side of the face. It is severe, as in extremely painful condition. Brief meaning lasts a short duration of time. Stabbing is you being stabbed by something. Lancinating is sharp shooting. So both mean extremely painful. Paroxysmal also means sudden, and recurring pain, that is it will occur again and again in the distribution of trigeminal nerve. Now, etiology. In etiology, we come across a word called idiopathic. So idiopathic means we do not necessarily know how this disease was originated and what exactly causes it. But over the years, we have come across many factors which might cause the disease. They include vascular factor, mechanical factors, anomaly of superior cerebellar artery, dental etiology, infections, retinas, jawbone cavities, multiple sclerosis, petrous-rich compression, post-traumatic neuralgia, intracranial tumor, intracranial vascular abnormalities, and viral etiology. So first is vascular factor, in which you have ischemia, autoimmune hypersensitivity, which can cause demyelination of the nerve. So ischemia happens when one of the part of your body is not being met with enough blood supply. So eventually that part doesn't get oxygen, vitals, any nutrients, and it starts dying. That is undergoes necrosis. Autoimmune hypersensitivity is when your body recognizes its own substances as foreign and starts giving exaggerated responses against it. So if this occurs and trigeminal nerve gets involved, it can lead to trigeminal neuralgia. Next, we have mechanical factors. So aneurysm of internal carotid artery can erode the intracranial fossa to exert pulsatile pressure on trigeminal ganglion. So on the right-hand side, you can see the picture of aneurysm. So what happens when an artery, if one of the walls of the artery is weakened, ballooning of the artery takes place. And this ballooning is called as the aneurysm. On the left-hand side, we have a picture showing the carotid canal. This is the place from where internal carotid artery is going to reach to the brain. On the right-hand side, you can see trigeminal ganglion. So for an example, if aneurysm of internal carotid artery takes place, with every passing pulse, it will exert pressure on intracranial bone. And over time, the intracranial bone will erode. And after that, this pressure will be exerted on the trigeminal ganglion. And then demyelination of the nerve will take place. So the next is anomaly of superior cerebellar artery. And this is the most blamed to cause idiopathic pain because it lies in proximity to the sensory root of trigeminal nerve. And in most cases of idiopathic TN, surgical decompression performed in this area has provided relief. Next, we have dental etiology. So Westrom and Black suggested that differentiation from loss of teeth and degeneration of nerve is not restricted to the peripheral parts and proceeds proximally to involve the spinal nucleus. So what this means is, say if you do traumatic extraction and the nerves beneath the teeth are injured, so the damage is not going to be restricted in that position, but it will start moving proximally and involve spinal nucleus. After that, you have infections. So infection of both types, granulomatous and agranulomatous. If they impinge on the nerve, it will cause trigeminal neuralgia. Then we have Ratner's jawbone cavities. So G.V. Black was the first who gave description of such cavities. He says, if the bone marrow undergoes ischemia followed by slight osteomyelitis, cavities can form, and these cavities can injure the nerve and cause demyelination. Then we have multiple sclerosis. So multiple sclerosis is an autoimmune disease in which your body eats away the protective covering of the nerves. Now, Olson suggested that if the sclerotic plaque is located at the root entry of trigeminal nerve, it can lead to trigeminal neuralgia. And the patient will have history of multiple sclerosis with a demyelinating disease. Then you have petrous-rich compression. So Lee suggested that the compression of trigeminal nerve at the dural foramen or the petrous ridge. And in this case, you have the slice of the petrous ridge to provide relief to the nerve. Then we have post-traumatic neuralgia. So trigeminal neuralgia following a traumatic event, say you punch somebody, you get punched by somebody, or there is a traumatic dental procedure, then trauma will occur. And if neuralgia following this is called post-traumatic neuralgia. Then we have viral etiology. So post-herpetic neuralgia is seen in elderly patients, and the patients will have a history of varicella zoster virus infection as well. Next, we have general characteristics. The incidence is 4 in 100,000, so it is a rare incidence. Age of occurrence is in late middle age or 5th or 6th decade. So it occurs in later half of the life. More seen in female. Affliction of side is right, and the degree of nerve involvement is mandibular, maxillary, and ophthalmic. So clinical features. So TN manifests as sudden, unilateral, intermittent, paroxysmal, sharp-shooting, lancinating, shock-like pain in one or more branches of the trigeminal nerve by slightly touching the trigger points. So it is basically the entire definition with introduction of one more word, which is the trigger points. So in trigeminal neuralgia, you will have trigger points. So these are the points on the face where slight stimulus will lead to the exaggerated pain. Pain is confined to one part of the trigeminal nerve, but it may spread to other parts. It rarely crosses the midline, lasts for a few seconds, but recurs with variable frequency. During an attack, patient grimaces with pain, clutches his hand over the affected side, stops all the activities, and holds or rubs the face, which may redden the eye and eye waters until the attack subsides. Male patient avoids shaving and the oral hygiene is poor, and the patient avoids brushing teeth. That is for obvious reasons. Paroxysm occur in cycle. So that means that one cycle might repeat after a few months, then few weeks, and then it keeps on occurring nearer and nearer. And with every passing cycle, the pain becomes more intense and more unbearable. Then, in extreme cases, patient has a frozen or mask-like face. Presence of extraoral or intraoral trigger points provable by stimuli are seen. So, touching the face, chewing, smiling, brushing teeth, shaving, washing face, even cold breeze of wind can lead to, can act as a stimulus. So, the nerve involvement will have the following trigger points. So if mandibular division is involved, it will commonly be, trigger points will be commonly localized on the lower lips, teeth, or gums of the lower jaw. In maxillary nerve, it will be the upper lip, ala nasal, cheek, upper gums. And for ophthalmic division, it is the supraorbital ridge. Characteristics of the disorder that attacks do not occur during sleep. So you can sleep well. Patient will lead a poor quality of life. Diagnosis. So there is no specific diagnostic test. And White and Sweet came with a diagnostic criteria to detect trigeminal neuralgia. So it goes as follows. So pain is paroxysmal. It begins with a light touch to the face. That is the trigger zone. Pain is confined to the distribution of the trigeminal nerve. It is unilateral. And clinical and sensory examination is normal. Then diagnostic methods. MRI, magnetic resonance imaging, and CT scan, computed tomography. It will help in identifying intracranial lesion or intracranial arteriovenous anomalies. Tablet carbamazepine and diagnostic injections of local anesthesia. So if a patient comes to you with the description of pain as similar to the trigeminal neuralgia, so first we will take the history, then we will do the clinical examination. If with the clinical examination, if we see that the patient might have trigeminal neuralgia, then we do the diagnostic methods. So after doing the MRI and CT scan, if we see no lesion and If we see a lesion, that means the cause of the pain is because of that lesion. But if there is everything is normal, then it could be trigeminal neuralgia. Then we have a diagnostic indicator, which is tablet carbamazepine. The speciality of this tablet is that it will not relieve any other pain except for trigeminal neuralgia. It relieves pain only of trigeminal neuralgia. Then diagnostic injections of local anesthesia are given. So these um, injection help in two ways. They help us to localize the trigger points, firstly, and secondly, they help anesthetize the patient. So there is temporary relief from the pain. Will cause temporary relief of the pain in the trigger zone. So materials needed are 3 to 1 cc syringes, 3 to 2 lidocaine, 2% lignocaine without adrenaline. So first, you take normal saline and then you inject it at the trigger zone. So if the patient says, okay, that no, the pain is gone now, that means the pain was psychological and it had nothing to do with trigeminal neuralgia. But if the patient says that the pain is still there, then we take lignocaine and provide it at surface site. Wait for 5 minutes. Now, if the pain is relieved, then we provide treatment only to the trigger zone. But if the pain is not relieved, that means the pain is of musculoskeletal origin, and we inject even more deeper. And after localizing the site, selective nerve block can be given. After that, you have the treatment. The treatment is divided into two parts. First is the medical management, then is the surgical management. Medical management is the first line of approach for most of the patient. One thing about trigeminal neuralgia that it will not respond to analgesics like NSAIDs and opiates like morphine. Anti-epileptic and anticonvulsant drugs are used. So first line therapy is oxacarbazepine and carbamazepine. Second line therapy is baclofen. Third line therapy, gabapentin. So carbamazepine, it is highly specific in relieving pain of trigeminal neuralgia and not the facial pain. It is also a diagnostic indicator, that is why. Dose is 100 milligram TDS is introduced and titrated until remission is achieved or other side effects or toxicity become unacceptable. So you give this patient carbamazepine and increase it until you find that the disease has subsided or there are weird toxic symptoms which are seen. Then dose should not be exceeded to more than 2 grams per day. And side effects are visual blurring, dizziness, skin rashes, drowsiness, thrombocytopenia, and aplastic anemia. After that, you have dilantin sodium or phenytoin sodium. It may be used alone or with carbamazepine. The dose is 50 to 100 milligrams 2 to 3 times a day. Side effects are drowsiness, slurred speech, abnormal movements, gingival hypertrophy, folate deficiency, hirsutism, swelling of lymph glands. Now, and also it is teratogenic drug. Patient prescribed these drugs should always refrain from driving, swimming, working in industries near machines to avoid mishap. Phenobarbiton and diazepam are prescribed as adjuvant therapy. So these drugs can be given additionally. Gabapentin 100 to 200 milligram 2 to 3 times a day. Clonazepam 1.5 milligrams per day. And clonazepam also substitutes carbamazepine in patients where it is contraindicated. Tablet oxycarbazepine 1,200 milligrams per day, valproic acid 600 milligrams per day. Its side effects are irritability, tremors, and hepatotoxicity, weight gain. Baclofen 10 milligrams per day. Now we come to surgical management.